Cancer care in senior patients, another of my areas of expertise. And also one of the areas I'm really passionate about is how to improve the care or how to improve cancer care in senior patients. Next slide, please. What is important? What is really important to talk about cancer in senior populations? A great proportion of patients with cancer are over the age of 70, and this is well defined. In any cancer center, roughly about 30 to 35 up to 40% of patients are over the age of 70, newly diagnosed cancer patients. And this is important to realize because this is a very specific population. So why? Senior patients present with other medical conditions or medical problems. Usually these patients have, besides the regular medical problems such as hypertension, diabetes, and so forth, they also have other medical conditions that make them very vulnerable in terms of whenever they're diagnosed with cancer for cancer care purposes. Senior patients may also present with some functional issues, meaning that they may not be as functional as they used to be. And of course, that also represents a challenge when we want to treat these patients. In cancer care, we look into what we call functional scores. And this is one of the main issues sometimes when we face these patients, that we need to define what we mean by a good functional score or a bad functional score. And the majority of patients have some functional problems, limitations, disabilities, and so forth. And of course, some of the treatments that we deliver may be too toxic for our senior patients. So we need to be able to strategize as to and deliver a more personalized therapy for these patients. Next slide, please. So what are some of the strategies that we can use? Of course, we need to understand what do we mean by aging. And this is important because I think is one of the factors that sometimes we overlook is the fact that we tend to see patients who are really functional, but then there is something called chronological age and also biological age that are two different concepts. So we go more with the biological age of the individual as opposed to the chronological age of the individual. So you can have two different settings, for, if you will. You may have a patient who is 55 or 60, but look like an 80-year-old, and vice versa. You may have an 80-year-old who look like a 60-year-old. And of course, that makes a whole difference in terms of which patient can get what kind of treatment. So we need to also understand how to improve therapy options. Chemotherapy is being delivered with less and less frequency these days. We're trying to use a more personalized approach, more of a targeted therapy approach. And this is something that perhaps in the future is going to help to improve the quality of life of this population, because quality of life is very important. We do have some patients who are 80, 85 years old, who basically get a recent diagnosis of a hematologic malignancy, for instance, and then these patients, of course, will like to spend as much time as possible at home as opposed to in a cancer center. So there are many new strategies that are being devised at this point to improve that sort of a specific time the patients may get with families as opposed to spend time here in the cancer center. Also, we need very adequate geriatric assessment tools. By that, we mean that we get certain tools in which we can control or we can predict some of the outcomes that this patient may have. It's not only based on functionality, but also in other aspects of the aging process. And that is very helpful to predict how patients are going to respond to therapy and what sort of outcomes we should be looking for. And also, is something important as part of the strategies is, and in many of the clinical trials that we do in oncology, meaning that in the design of a specific clinical trials in preparation to develop new treatment regimens, unfortunately, many senior patients have not been included, and this is something that we need to change if we want to improve outcomes on this population. Next slide, please. So in conclusion, we need to improve the expertise in geriatrics oncology. We tend to see more and more of these patients in a regular cancer center. And here at Miami Cancer Institute, we have a program called a geriatrics oncology program, in which we not only see patients from the cancer care standpoint, but also from the geriatrics standpoint. And we try to develop and work with our geriatricians so then we can improve the outcomes of the population. We know for a fact that senior patients need to be included in clinical trials. For many years, they have not been included, especially the patients of the age of 70 or 75. That is changing, which is a good approach. but definitely we need to keep improving that inclusion of patients in the clinical trials. And of course, as we saw in the case of HIV oncology, for geriatric oncology, also we need a multidisciplinary approach. Because remember, we need geriatricians, we need case managers, navigators, and social workers. Other specialties are going to help us in the care of patients, senior patients with cancer.